Well, thank you very much, and good afternoon, everyone. You can tell from my voice that I haven't either spent all my life in the USA nor working in the VA. When I first started working in the VA, I managed the programs I now manage from Washington, D.C., from Denver. I traveled around a lot, and I got to see 40 or 50 VA medical centers in the first 4 years and really learned the nuts and bolts of how things were done. When people asked me where I came from, I would say, I come from back east. They give a kind of double take and they'd say, you mean it comes from way back east? Our last speaker talked about shipbuilding. Imagine me as a kid, age 12, 13. When I was that age, what I wanted to do was salvage ships. And that's what I was going to set out to do. And then when I was 16, I was riding a motorbike with my best friend Gary and another friend in the lanes in villages around Oxford. And Gary had just got a new bike, a BSA, and he sped past me, sped past the guy in front, and he misjudged a bend, and he got hit by a Land Rover. Now, he got hit, came off his bike. Thankfully, he was okay in terms of he survived, but he badly damaged his right leg. I was not really capable of understanding what to do, other than very vaguely help stop the bleeding. And I say this because I was a kid who had a passion to try and mend things. I like to mend things and make them work. And so I changed my mind and decided at the age of 16 I was going to go to medical school. So I did art subjects, English, economics, economic history. I went to medical school, and I changed my mind through medical school and decided I wasn't going to be an orthopedic surgeon, which the limb damage had made me think for my friend Gary. I decided I wanted to do neurosurgery. So I did neurosurgery, trained as a neurosurgeon, and at the age of 33 was really all set to go forward and spend my life fixing people in terms of the vocation of doing neurosurgery, and was very interested in the behavioral effects of head injuries, behavioral effects of neurological disease, and that was going to be my life. And I trained as an epilepsy surgeon. But there was something that made me change my mind, which was around the system I was working in. And let me just sum up two kind of things around that system. So what I was doing, about 20% of the work was head injuries. And about 10% of the head injuries that we saw were people who might have a blood clot inside their head. Now, whether we took that blood clot out in 20 minutes versus 40 minutes made a big difference to their survival. However, if it was taking 4 hours instead of 30 minutes to get them from where they were first seen in the healthcare system to where we were working, it was kind of, where were you really going to make the difference? And so it wasn't just getting people to care. Let me give you another quick example. Let me give you a sort of composite of patients. Imagine a 12-year-old boy knocked off his bicycle by a delivery truck. This 12-year-old boy taken to the local hospital has trauma, orthopedics, and general surgery. He's seen, and the orthopedic surgeon seeing him rings up me at the neurosurgery unit, says, I have this child with brain coming out of the wound in his head. You have to take this child straight away. I say, sounds harsh, but if there's brain coming out, he's actually decompressed, and so he's not at specific danger of his head injury at this moment. But let's just go through a standard checklist. What's his pulse? What's his blood pressure? What's his respiratory rate? We checked his chest, cervical spine, limbs, the things you do. Child has a blood pressure of 70/30, pulse of 160. He's shocked. So I say to the orthopedic surgeon, he's not going to die from his head injury. Don't transfer this patient. Make sure you've transfused him up, stabilized him, etc. Won't go through because I could spend too long doing it, but essentially the child's transferred in a huge rush and arrives 40 minutes later with virtually no blood pressure and blue, and requires to be resuscitated, has a ruptured spleen. His head injury is in fact not that serious. It's compound depressed skull fracture. The child ends up severely disabled from anoxia. He's one of twins, spends 2 years in rehab. The family ends up that they don't stay together, they divorce because of the complexity of dealing with this child who's problematic. So why I say that is there's a real schism in the healthcare system around the locus of where decisions get made. So I decided to change what I was doing, did a master's in public health, worked at a research and policy institute called the King's Fund in London, and did work around shared decision-making and moving services out of hospitals into other settings. And I got exposed doing that to telehealth, the idea that you can actually change the location of healthcare decision-making by using technology. Now, somebody said to me at the time, where would you most like to work in order to be able to take this forward? I would have said I'd like to work at the VA Department of Veterans Affairs. The reason being, what I was doing in telehealth was really interesting. I was doing projects and pilots. But again, I was unsatisfied because what wasn't working wasn't the pilot, but it needs a system to implement it. So what I'm going to talk to you is how you take innovation, in my experience, from a pilot or a project, and you think about how you innovate it at scale, and you create the systems to support it. So by happen chance, which again, I won't spend the time explaining, in 1999, I got the opportunity to come and work at the VA, the US Department of Veterans Affairs. At that time, it was the end of a period where Ken Kaiser had been the Undersecretary for Health, a period of tremendous innovation where the VA was transformed. And at that time, the telehealth going on in the VA, aside from teleradiology, was of the order of a few hundred patients. So what I'm going to do is describe essentially where we've come to and some issues about how we've got there with you for the rest of my time. So VA is recognized as a national leader now in telehealth. And we provide care using distance technologies, 150 hospitals into 750 other sites of care. Last year, in 2011, 380,865 patients had care using these kind of technologies. More than 100,000 of these, it took place in rural and remote locations. As we plan now, we're looking towards this year reaching some 480,000, and next year, 820,000 patients getting care using these kind of modalities. So what has been possible to do over the course of, I started in 1999, built teams, and what I'm about to describe is not my innovation, it's working with really very talented people, has been able to take this to a very large scale and to move it forwards. So this year, we will have seen something like 9% of veterans will have received care via telehealth. Next year, we're aiming at 15%. Now, when I say telehealth, I think when this all works its way through, as it will, that we'll just call this the way healthcare is delivered. But from the point of view of my purview, I'm involved in 3 programs, which I'll quickly describe. One is home telehealth. That really provides care to people with chronic disease, people who otherwise would be perhaps in long-term institutional care, diabetes, heart failure, post-traumatic stress disorder, depression, chronic obstructive pulmonary disease, etc. As you're sitting here, I'm standing here, there are 74,000 people who are able to live independently in their homes based on the services that we have as we are here. The second program I'm going to talk about is called StoreForward. Takes digital images, it sends them to be viewed elsewhere. 20% of VA's patients are diabetic. So teleretinal imaging, taking images of the retina, sending them to be viewed elsewhere, avoids sudden blindness. Other areas we do this in, dermatology and wound care. And the third area is something we call clinical video telehealth, which replicates a face-to-face clinic appointment. So instead of somebody having to travel perhaps 100 miles, 200 miles, or in a large city, even traveling 2 or 3 miles can be a major burden, it's possible to be able to see remotely, get specialist advice, which is delivered to you using technology. Just to give you a sense of how this has grown, and these are the figures from 2008 through to 2012 for the home telehealth program, for the StoreForward program, and lastly for the clinical video program. So you can see a kind of growth curve which is going up like that. Again, I could spend a whole time talking about this, so just in brief, I would say one of the things about all these 3 areas of care has been to define a very defined model of care of how this is done, critically work it through, because things end up getting into trouble when you scale because you have to transform relationships into processes. So making sure the processes are stable. I would also say that of the processes which have been the ones most that have put the programs at risk, they've been the technology. Purchasing technology often from venture capital companies. Technology which wasn't thought it was going to be doing things at the scale we've currently reached. Now, the benefits for the organization I work in of doing this are the VA covers care for continental USA, Puerto Rico, US Virgin Islands, Hawaii and the islands, and Guam, and so has a tremendous reach. And despite 152 hospitals, 1,100 other sites of care, the ability to access care is still limited. So this is a way to really improve access to care and to improve decision-making in the way that I described. I described decision-making for two things related to neurosurgery. I won't spend the time, but if you go through almost any area of healthcare, you can find comparable reasons why there's a mismatch. If I were to ask somebody in the audience and say, describe the care of a relative, a friend, a colleague, I would bet you, in almost every instance, what I would hear is the problem with the coordination of care. Individual pieces were okay, but decision-making was awry in terms of getting things done. And there are two aspects to healthcare, and I don't think they get proper recognition. One aspect is the technical thing that needs to be done, and I say technical very loosely, whether it's surgery, medication, information, advice, whatever. The second thing is getting the right patient to the right intervention. And certainly that's one of the pieces which I don't think, and that is what telehealth is very good at helping provide. So the rationale for doing it, in terms of some of the other outcomes that I can just show you, our home telehealth program reduces bed days of care by 53%. How does it do that? I'm not aware of any evidence that an outpatient clinic for chronic disease is the way to see somebody. If you ask anecdotally, somebody may deteriorate 2 days before, 4 weeks after that outpatient clinic appointment. They then, in any healthcare system I know of, generally get their access to care by being in extremis. The heart failure patient is at death's door, perhaps, and spends 2 weeks in an ICU. Why not actually monitor somebody when they start to deteriorate? And this isn't acute care, I have to say. Then what you can do is actually end up intervening, either by phone, providing chronic care management, or else admitting them perhaps urgently to hospital or to a clinic appointment. We've had an 86% mean satisfaction score with the patients and 92% with the StoreForward program. And we're seeing reductions in travel expenses. And with the home telehealth program, we're seeing savings of the order of $1,800 per patient per year. And by those savings, that's with all costs, including the telehealth in place. So with 74,000 patients being managed at this moment in time, 100,000 in total during the year, and savings of $1,900 per patient, you can see that that mounts up to quite large amounts of benefits to the organization. And quickly, a few words about a major area, as you will be well aware, Telemental Health, where in order to deal with people who've got chronic mental health problems, telehealth really lends itself, especially in remote and rural areas. It also is a way to be seen for care without necessarily the stigma of being seen in a mental health clinic. You can be seen locally in primary care. And we're in the process of using IP video onto people's own PCs and laptops to provide care in terms of mental health care, rehabilitation care, directly into people's own homes. We've seen a 25% reduction in utilization, and with home telehealth, of the 1,041 patients we reviewed and managed, we're seeing 30% reductions in admissions for home telemental health. Now, I said I'd talk about the systems, just some of the unique challenges that have been in place to take this program forward. Firstly, telehealth training isn't offered in any medical schools. When you go beyond a pilot, you end up having to making sure you have a constant supply of people able to run the program. No outside resources exist to train providers outside the VA. Now, given the disparate pieces we have to pull together in technology, in clinical practice and otherwise, there are 60 requirements to establish some of our programs. So in order to do this in a systematic way, we have to be able to train and make those things available. The Joint Commission, when it goes around and inspects healthcare systems, it doesn't inspect specifically for telehealth, but it does, with its tracer methodology in our organization, almost invariably now come across telehealth. So having a quality management system in place is really important. We have 3 training centers that develop and provide standardized training. These training centers provide 98% of that training virtually. We trained last year of the order of about 4,000 staff. So training has not been an issue in terms of taking this forward. Standardizing the program, standardizing the processes involved, standardizing the technology allows this kind of training to take place. So the vision of it is that there's a national system in place where there's no reason why a veteran who might be in the Upper Peninsula in Michigan, who has multiple sclerosis, he or she might be able to discuss a swallowing problem with a specialist MS center. We have 2 of them, one is in Baltimore and the other is split between Seattle and Portland. The ability to do that, the system you have to have in place, has to be something which is interoperable, not only in clinical practice, but also interoperable in terms of the technology. So we provide the required training and tools and resources to be able to do this and integrate across with other programs and have a series of master preceptors who are able within the organization to be responsive to changing what we're doing and new needs. So I'm going to finish by just summing up, and each one of these I could provide a whole 18-minute talk to, so I'm just going to go through very quickly. But in terms of developing large systems like this to scale, firstly, you have to ensure the programs are based on patient need. Very simplistically, I believe that if you look across any healthcare system, by and large, money follows patients. So this is about developing high-volume, low-cost applications to develop large networks. And if you don't have defined patient need, if you're trying to develop something which is too esoteric, it's equivalent to trying to build a pyramid where you try and put the top piece down and then build downwards. So this is about building a pyramid from the bottom upwards, and all that we do is in fact based upon the ability for decision-making to be based on having an electronic patient record. I've talked about standardizing technology in clinical platforms. Essentially, I've also talked a little bit about converting relationships to processes. When people have a really good pilot in place, if you look at it in detail very often, you'll find that a lot of what's being done is done by relationship rather than process. When you take something to scale, those relationships start to fall apart. You can't replicate them. The VA, many people, when they sort of ask about what they're doing, they say, well, firstly, they confuse the VA with the military healthcare system, the Department of Defense healthcare system. And they think that in terms of implementing a program like this, because there's a sort of military link, it must be that I work in a position where I and my colleagues just mandate things to happen, and lo and behold, they all happen. It does not happen like that. Anybody who's worked in any healthcare system, 152 hospitals that work autonomously in many ways. So essentially, what this is about is managing complex adaptive systems. And managing quality, I've talked about. We have an accreditation process in place. We internally accredit. We have dashboards that compare and benchmark quality. We can capture workload, manage data. And I've skipped through those last couple quickly because I'd like to say that this is, in the end, about building communities. How this has worked, what makes this real fun to be able to do, is the concept of doing this, the concept of operations, the systems I and my colleagues design. We don't end up putting them out there and just say this is how it's going to be done. We work very, very closely with users on the ground who link to patients. And I don't end up saying, if I hear somebody criticizing something or saying this isn't working, I don't say, look, the idea was good, there's something wrong with the way you're implementing it. I was going to say listen, but from earlier speaking, I'll say I observe. So I observe, and I want to know what's going wrong. I want to be the very first person to know what's not right. Now, doesn't mean I'm obsessional and crazy. Sometimes it's something in the implementation and there is no problem, but it's learning as you go along. And the last piece I would just say is there's an area of telehealth which has been around for over a century, which is the telephone. We have no clear idea how the telephone is used in healthcare. It's certainly changed it as it transformed it. We can't quantify what's being done. There's no training of people to use the telephone. And I'd put to you, everything which is currently involved in telehealth is all going to happen. Healthcare will take place using video, digital images, you name it. But if it happens in the same way as the telephone did, there'll be no way we really understand what it is. So I'd put to you the real importance of this, which is going to happen anyway, is to get out in front of it and to lead where that change is. And I put touching patients. When I was a medical student, I spent a summer in Cork in the south of Ireland. And when I was there, the professor of surgery I worked with came back after a lecture tour. We went round and did rounds together in a slightly more, if you like, civilized time, where it was time to sit, have coffee. When we were having coffee, he said, "You may not have noticed, but I touched every patient. I might have just held their ankle for a moment, patted them on the back, shook their hands." And he cleaned his hands, so there was no issue about infection control. He said, one of the things in healthcare is no patient should ever feel untouched. Now, nobody ever said that to me again, and I would just say, in terms of what we're talking about, whether it's the technologies I'm talking about or otherwise, the real challenge, and in fact, the real joy in doing this kind of work, is in the end, it's all about relationships. And if it's going to work, we have to find ways to get these kind of technologies to touch patients. So thank you.
Let me ask you a couple of very naive questions. How do you do a blood test using this technology?
Well, this is not about a sort of panacea where everything is suddenly going to be done using technology. So this, if you like, supplements and is used in conjunction with routine ways of delivering healthcare.
Although it seems to me that eventually you could get, I mean, if we've got Amazon, you could do delivery of various kinds of, blood, urine, that sort of thing from home without necessarily relying on traditional outpatient services where somebody has to come somewhere and do something. And there's all kinds of telemetry that you could hook people up to that doesn't require them to change a room in their home. How have you relied on that sort of thing?
Well, absolutely. I think two things around that. Firstly, this is about moving care into the home and local community. So in our instance, if somebody's seen in a local community clinic, blood tests, other investigations are done there. Many instances, it's not actually necessary to do a blood test. 80% of history, and 80% of diagnoses are made on history. So it's often just asking routine questions. And as you just alluded to, as we look forward into the future, complex hematology and other tests which are now dependent upon laboratories and hospitals, the future is going to be upon us, where just as you say, it's going to be possible to do these kinds of things in the home or very close in the local community.
In the unique challenges you described, the levels of certification and the various criteria that are required to get people sort of ramped up to be able to do this effectively, are those obstructions that exist in the system, or are those your self-made criteria which suggest that it's actually hard to train people to come through a Skype connection or a telephone connection and behave in a way that's going to produce quality information from a patient, create that trusting relationship, that sort of thing?
Well, I mean, healthcare is heavily regulated and highly litigious wherever you go. It varies a little bit in the world. So part of this of making it work is if you have a small pilot or a project, it can kind of sit there. But if you're going to end up doing something at large scale, you have to adhere to common policies and procedures which are there in place. Now, you can either say, well, these are barriers and be against them. But one of the things about going through the kind of things I've been talking about is they mean you have to critically think through all the little pieces to make this work. One of the expressions I way overuse is the devil of this is all in the details. So it's very easy to vision this. I mean, to end up saying, I've got this wonderful vision, I've got this vision that this is going to be, healthcare is going to be in the home. People are going to be, empowered to do things, going to be this information. Easy to do. The devil is then the details of how you make it happen.
And what sort of implementation targets do you have where you can say, I mean, I saw the impressive numbers that you have of people using the system. You've gone from 160,000 to 240,000, and you expect in 2 years to be at 840,000. Is that a result of demand-driven and service-driven evolution of telehealth at the VA, or is it a result of increased population because of the wars in Iraq and Afghanistan?
I mean, the population is changing. In many ways, what's happening in the VA is a forerunner of what's happening elsewhere. Though the population has traditionally been skewed more towards males, certainly women are much more part of the veteran population. Generally speaking, the population is older and sicker and poorer. And it's a forerunner in many ways of that older population that comes from cohorts that have come through from different wars. The numbers from the current conflicts are high, but essentially there's still a preponderance of amount of things which are done relate to those older generations of patients which are there. So in terms of the need to do this, I mean, it's certainly changing expectation and access. If I were to ask folks in the room, who in the room as they get older is thinking what I would most like to do is go into long-term institutional care in a nursing home? So we don't.
A lot of hands there, oh yeah.
This is about veterans who would like to end up being independent, living in their own homes. So in many ways what we're doing is building on things like the electronic patient record to really change the location of care and how things could be done. The other thing is really, I should just say, the success of the programs. And before I joined the VA, I used to be on advisory boards of a number of organizations. And one of the things that we used to do was before we took a program out, we would end up getting together for a couple of days. And what we would do is we would brainstorm and go through the details of exactly what that program was going to be. It cost about 22,000 to get a group together for a couple of days. To take a program out and implement it can cost you $70, $80, $90, $100,000 on a small scale. To take it in production might be $2 or $3 million. So if you're really going to make your mistakes, we should learn where it's going to cost you 20,000. So a lot of what we end up doing is spending a lot of critical time at the beginning, making sure we thought through things and got them right. Because there's nothing sadder than see somebody who's done a great pilot, and at the end of the pilot, they're saying, well, we would really like to take this to scale. But if you look in detail at what's been done, intrinsically, they haven't got the processes right, and it's not going to go to scale. You have to go back and repeat.
I started my career in journalism back in the 80s when the VA, and I was covering Vietnam vet era issues back then. The reputation of the VA was, I mean, dreadful is a generous term for it in terms of people's dissatisfaction with the system, expectation that it wouldn't work, and a feeling of dealing with an utterly faceless medical bureaucracy. That is no longer the case. Why?
Well, I would just say quickly, when I first joined the VA in 1999, and I used to go around and talk about what we were doing, when I was talking to large audiences like this, I would say, we're doing this in the VA in a way that my anticipation of the audience they would say, well, if the VA can do it, more or less anybody could do this. And it's changed. Now, how has it changed? Why has it changed? It has changed very much because of the mission of the people. I talked about the transformation with Ken Kaiser in the 90s. That transformation has continued onward. And the innovation, the use of technology to change the location of care. But once you stimulate a group of thousands and thousands, tens of thousands of people to be innovative, to think they can do something in a different way. So what I would just pass on to people at large with that, here was a healthcare system which people would have said back in the early 90s. This is an example of how not to do things. 20 years later, it's something to be emulated. So I asked the question last night. I said, is this change going to be incremental in terms of what we're looking for? I believe this change can be transformative. I work in an organization that's made those sort of transformative changes.
Dr. Darkins, thanks so much.
Appreciate it.
Yeah.